Thank you. I have a pleasure to continue the session. And we will now discuss the outcome of two major conferences held earlier this year. They are again under the agenda item 5E, report on the WHO high-level meeting, health system response to NCDs, experience in the European region held in Sitges, Spain, in April this year, and agenda item JET report on the WHO high-level meeting health system for prosperity and solidarity, leaving no one behind, held in Tallinn, Estonia in June. The relevant document is Euro/RC68/19. The outcome document of both meetings can be found in Euro/RC68, informational document /3 for the Sitges conference, and Euro/RC68 in informational document /6 for the Tallinn conference. We will also consider a draft resolution linked to these agenda items, which can be found in Euro/RC68 conference document /8 review 1 with the financial implications included in the document Euro/RC68/19 point edit 1. We will have two separate discussions for each the agenda item, and at the end of these deliberations we will consider the draft resolution. Let me welcome here on behalf of all of us Dr. Bente Mikkelsen, the new Director of Division of Non-Communicable Diseases and Promoting Health Through the Life course. We are looking forward to work with Ms. Mikkelsen. I would like now to give the floor to Dr. Hans Kluge, Director of the Health System and Public Health, and to Dr. Bente Mikkelsen to introduce this topic. Hans, please, you have a floor.
Good afternoon, dear Mr. President, Regional Director, Executive President, Deputy Executive President, ladies and gentlemen. It's my great privilege now to kick off the sessions on people-centered health systems for the future, during which we will report on three elements. The first one is the outcome of the WHO high-level meeting on health systems response to NCDs, which was held in April in Spain, together with our sister division, the Division of Non-Communicable Diseases, headed previously by our brother Gordon Galea, and now, as Professor Amran was telling, our sister Bente Mikkelsen. The second element is reporting on the outcome of the WHO high-level meeting on the occasion of the 10th anniversary of the Tallinn Charter, which was generously hosted by the Ministry of Social Affairs of Estonia in the beautiful city of Tallinn in June this year. And we did this together with the European Observatory, Dr. Joseph Figueras, Professor Mark McKee and the team. And the third element will be on the final outcomes of the regional report on financial protection by our Barcelona team, answering the question, can people afford to pay for healthcare in Europe? All these are critical milestones on our joint journey moving towards universal health coverage and the Sustainable Development Goals. In fact, what we did the last 10 years under the leadership of our Regional Director, Susanne Jacob, is what we call to turn on the heat under the burning platform of comprehensive people-centered health systems. And each of these meetings provided new perspectives, new evidence, which added to our previous knowledge of people-centered health systems on the journey which started in '78 with the Alma-Ata Declaration, moving to the Ljubljana Charter, the Tallinn Charter, and then to the meetings we are today. We will table a resolution with the key elements of both meetings, because we see these two meetings interconnected. We're very much looking forward to your comments on this joint resolution and eventually adoption so that we can put the resolution in our backpack when we are going to New York next week on the high-level meeting for NCDs and TB. From there to Astana for the 40th anniversary of the Alma Ata Declaration on primary healthcare, when the new global vision on primary healthcare will be tabled, and from there then to the UN high-level meeting on universal health coverage in 2019. This is all a work of a great team in the division and between divisions, and we will present it as a team. So now I'm handing over the relay to Bente.
Thank you, Hans, and Excellencies, President, Vice Executive Director, Regional Director, friends. I'm now speaking from the perspective of NCD, and I am very, very pleased to share this moment with you. And you know that for a decade we have really focused on the best buys as interventions from NCD. And this opportunity, this great work has really made it possible for us to see how can we make health system respond to NCD. And this is important. It's important to transform health system to really have a maintained and lasting effect. And I think a very important aspect of the work is also that we have been able to focus on success stories and also inspiring examples. And I am personally taking this forward, and we will reflect on this during the high-level meeting on NCD next week in New York. But moreover, I would be very, very pleased to continue the work and use this model, use this collaboration, this integrated work to both continue on the things we are doing, but also expand to use this into the area of mental health, NCD, and also air pollution as a risk factor for NCDs. Thank you very much.
Thank you, Hans. Thank you, Bente. We now move to agenda item 5, JET, about the high-level meeting on health system response to NCDs held in April in Spain. The Secretariat has prepared a slideshow for us to relive some moments of the meeting. Please, slideshow. Thank you. I now invite Dr. Melita Jacobs, Senior Health Economist, to introduce the outcome of the high-level conference on the health system's response to NCDs. Dr. Jacob, you have the floor.
Honorable delegates, ladies and gentlemen, I'm very pleased to stand in front of you today to report on major milestones of our work program, Health Systems Respond to NCDs. I'm honored to make this presentation on behalf of our large and multidisciplinary team in our two divisions of health systems and non-communicable diseases. At the heart of this work program is the premise that making a greater impact on NCD outcomes requires to scale up the best buys more aggressively than we have been doing in the past. And this in turn requires a comprehensive and aligned health systems response. We have been working for 6 years to unpack the main components of this comprehensive and aligned health systems response. Our approach has been multidisciplinary, grounded in country experiences, and focused on pragmatic and actionable policy recommendations. During this time, we have produced, with your enthusiastic participation, 12 country assessments with policy dialogues and implementation follow-up, 22 good practice briefs capturing the frontiers of health system strengthening in Europe, 5 annual training courses with more than 300 participants, and 3 consultative meetings with member states and experts. At the high-level meeting in Sitges in April, we shared, discussed, and even spiritedly debated the key policy messages emerging from this work. The meeting was attended by 200 participants representing 40 member states of our region. The results of these 6 years of work and the deliberations in Sitges have been captured in our synthesis report and the compendium of good practices. We are very pleased to launch these 2 reports here during this regional committee. I hope you will join us tomorrow at lunchtime to get your own copy if you haven't done so. We believe this report will be very useful for the coming decade as a handbook of health system transformation. NCDs have been labeled a wicked problem due to their complex web of interrelated determinants. There are no magic bullets. There are no single policy solutions to address NCDs in a sustainable manner. What is needed is systems thinking. This is why health systems play and must play such an important role. But health systems also need to transform and adapt to this wicked problem. An effective response will have to be comprehensive, intersectoral in nature, multi-pronged, connecting different types of health and even social services, cut across levels of public and private sphere, and connect different levels of public administration. Therefore, alignment of the different pieces is critical to achieve policy coherence. This makes comprehensive health systems transformation as much of art as science. These messages are also echoed in the new report to be discussed tomorrow, Advancing Public Health to Promote SDG Implementation. Health systems are responding to NCDs in the European region, as our 6 years of work has shown, and we captured the essential elements of this response along 9 cornerstones. Let me connect these pieces together through 2 examples. Many of the NCD best buys require public policies and fiscal policies which are intersectoral nature. Health systems are adjusting and playing a much greater role in making intersectoral action happen. Health systems catalyze action across sectors, synthesize and provide evidence, propose joint policies to stakeholders, take stock of progress, evaluate impact, and keep the policy cycle going. To make this work, however, there needs to be sustainable governance structures dedicated to these tasks with skills and resources. There is great variation in the types of governance structures that can carry out these tasks. They may be in ministries of health, they may be in public health agencies, they may be in local government offices. No matter which structure, we observe 3 important enabling factors to make this work efficiently. First, this requires transforming public health education in quite a few countries to yield a new cadre of public health human resources ready to transform the health system into a health-promoting and disease-preventing one, and ready to engage in intersectoral action at national and subnational level. Second, it also requires rethinking priority-setting approaches in the allocation of the budget and of the health budget to ensure substantially greater investments into health promotion and disease prevention. From the health system side, this requires to strengthen institutions and capacities for effective fiscal dialogue and making the business case for investing in health. Finally, scaling up population-based best buys and addressing even more upstream determinants of NCDs, such as early childhood development, education, labor market participation, requires adopting new financing mechanisms for intersectoral action. Our report details different examples of funding intersectoral action, including conditional funding, pooled funding in autonomous agencies, mandated funding set aside within each sector for intersectoral work, or leveraging resources from other sectors using evidence and information. A second policy area we have paid great attention to is how to remove barriers for early detection and condition management, particularly for cardiovascular disease and cancers. Making these health services more people-centered in practice requires to acknowledge that people and their carers are the frontline workers for NCDs. Health systems must become strong advocates for involving people, involving patients, and involving their caregivers in service design, empowering them, supporting them, and giving them a voice, especially to those most vulnerable. These are new expectations, and these expectations are leading to the transformation of primary healthcare services throughout Europe. Primary healthcare is becoming the nexus connecting different services previously compartmentalized: health promotion, disease prevention, early detection, condition management, empowering patients, empowering caregivers, and social services. This is a major expansion in task profile, requiring significant adjustment in the operating modality of primary healthcare. The model of the single physician and nurse duo working in isolation is becoming the past. They cannot cope with this new reality. The future is larger, multidisciplinary primary healthcare teams with access to information and powerful analytical tools for sophisticated population health management. These primary healthcare teams are increasingly connected regularly to specialists and hospitals through integrated information, communication, and record-keeping systems. This helps to move the specialist to the patient rather than the patient to the specialist. Appropriately regionalized specialist and hospital services are essential for providing timely acute care and improving outcomes under resource constraints. This again requires rethinking the skill mix in primary healthcare and our approach of training health workers. A cascade of task shifting is already happening in many countries, from specialists to generalists, from physicians to nurses, from nurses to care managers and social workers. Demand for healthcare over the next 3 decades will be driven by NCDs, and the greatest demand will be for health promoters, nurses, behavior change and mental health specialists, and carers. A few countries have already gone ahead the curve to create a workforce fit for purpose to respond to the growing burden of NCDs, but in others, these skills are in short supply relative to the growing needs. The inclusion of evidence-based, cost-effective NCD medicines in the benefits package is critical, regardless of the way in which we deliver primary health care. Looking through the lens of NCDs, it is clear that the sum of financial incentives in most health systems continues to undervalue health promotion, disease prevention, and good condition management. They continue to be structured by the level of care and treatment episodes, They reward diagnostics and intervention-heavy approaches. It should not surprise us that integrated, continuous, and comprehensive services are emerging more slowly than we would like to see. While adjustments on the margin are underway, large-scale, bold changes are necessary to our financial incentives if we truly want to leave behind the era of uncoordinated, episodic, and fragmented care. Let me now turn our attention to the equity dimension of the health system response to NCDs, including social determinants of health. Strengthening the equity orientation of health systems and embedding health equity considerations in public health action are important in order to leave no one behind. For this, universal policies are the backbone of the health system response. However, we have learned that one size does not fit all. We must also identify targeted approaches to enhance health equity. For example, universal smoking bans in public places is a best buy. But to reduce inequalities in smoking rates, we must combine it with public health action which prioritizes workplace interventions on smoking cessation in low-income and less secure areas of employment with subsidized nicotine replacement therapy. Health systems play a key role in reducing health inequalities, combining universal with targeted policies. Health systems can lead the design and implementation of these policies, but in the era of whole-of-government approaches and intersectoral action, health systems also collaborate and co-produce and catalyze and inspire. You know very well that we in the European region, we are a success story in the reduction of premature NCD mortality and managing chronic conditions. But could we be doing much better? Even though high-burden countries are catching up, projections show that it will take 6 decades to catch up. What would it take to not only ride this wave, but to make dramatic reductions in premature NCD mortality? Is it possible to leapfrog? This is the question we addressed in the special issue of the EuroHealth Journal, together with the European Observatory, collaborating with policymakers and health systems experts from Europe. Leapfrogging implies a large-scale qualitative change, changing tracks quickly, adopting today's best practices. There was great enthusiasm about leapfrogging opportunities in Sitges, and participants came up with many exciting ideas. For example, engaging public health services more dynamically in intersectoral action to address social determinants of NCDs. Applying gender-specific approaches in engaging people in primary care for earlier detection and better condition management. Using full capitation payment for the totality of care rather than just for primary care. Introducing new cadres of health workers requiring fewer years of training in areas of health promotion, caring, and nursing. The many ideas of leapfrogging are out there. So what does it take to exploit these opportunities? It requires paying attention not only to the what, but also to the how of health system transformation and managing the political economy of change. 2017 and 18 were very important for our work program on the health system response to NCDs. But it is not the end. It is a new beginning. Our joint efforts to synthesize what we have learned and share them in our report and our meeting signal the start of a new cycle in this work program. The cycle to share widely, the cycle to put it to the test, the cycle to focus on implementation, the cycle to show that leapfrogging is possible. We in the WHO Regional Office for Europe stand ready to continue to work with all member states to jump into this new cycle. Our commitments are included in the resolution in front of you. We are ready to provide leadership and expertise on health system strengthening and coalition building to create and manage change. We are ready to operationalize equity-oriented, comprehensive, and aligned health system strengthening. We are ready to create opportunities for regional exchange and sharing of good practices. We are ready to channel the results of these two high-level meetings to the UN high-level meetings next week and next year. And with this, I thank you for your attention, and I look forward to your interventions.
Thank you very much, Dr. Jacob, for this excellent summary. Now let us continue with the deliberation on this agenda item. I'm inviting those member states wishing to take the floor to raise their name flags, please. Starting from Austria, please.
Mr. President, I'm speaking on behalf of the European Union and its member states. Since our regional proposals are not fully reflected in the draft resolution contained in document Euro/RC68/conference document/8 revision 1, we propose to add a para OP3D line 3 after the word that, the word excessive, and in the same paragraph in line 4 to replace R by can be, so that the OP3D now should read as follows. Excuse me if I be so technical, but that's what I have to read here. To support systematic monitoring of financial protection and unmet need for health services, to support the assessment and equity impact of policy changes, and to improve access and financial protection to everyone, recognizing that excessive, that's the first word, out-of-pocket payments for outpatient services and medicines can be, instead of are, can be a significant source of financial hardship in many countries in the region. Thank you for your consideration of this request by the member states of the European Union. Thank you very much.
Thank you, Austria. I would like to ask delegates from Estonia, followed by Switzerland.
Thank you, Mr. Chair. I am speaking on behalf of the Nordic and Baltic countries, Denmark, Estonia, Finland, Iceland, Latvia, Lithuania, Norway, and Sweden. Congratulations and thanks for this well-organized high-level meeting in Sitges. The comprehensive outcome statements from the event fits in very well with the outcomes of the Tallinn meeting and will be valuable input for the high-level meeting on NCDs in New York and for the second global conference on primary health care in Astana. Strengthening health systems for more effective prevention and treatment of NCDs is central to implementation of Health 2020, the European policy framework for health and well-being, and supports the attainment of the SDGs and is closely linked to the achievement of universal health coverage. At the same time, we need to find a balance wherein which we strengthen health systems and address environmental risk factors like air pollution. And we need to be able to support healthy choices and lifestyles to tackle NCDs. Risk factors like harmful use of alcohol, tobacco, nutrition, and physical activity need to be tackled in cooperation with other sectors and stakeholders, and based on the health in all policies principle. Furthermore, we also need cross-border collaboration at the international level to be successful in this intersectoral cooperation at national level, especially with regard to topics like marketing in new media and its possible influence on youth. The best buys identify interventions to tackle harmful use of alcohol. That is one of the 4 most common modifiable and preventable risk factors for major NCDs. The global strategy to reduce the harmful use of alcohol, adopted in 2010, and the European Action Plan to reduce the harmful use of alcohol 2012 to 2020 has been the most crucial documents at the international level to support and guide member states from Europe in their struggle against the harmful use of alcohol. In 2020, the global strategy will have its 10th anniversary, and the European Action Plan will expire. It is the perfect time to start preparing for the anniversary, and that would be also a good time to discuss and celebrate the success we have achieved, and also discuss the challenges we have, and plan actions for the future in the European region, as also called for by Slovenia on Monday morning. We take note of the fact that the proposed agenda for the next EB has NCDs as an information matter. Based our want to see further work on NCDs, we wonder whether this agenda item should be more strategically placed on EB agenda. Thank you.
Thank you, Estonia. Switzerland, please, followed by Germany.
Madame la directrice régionale, Monsieur le Président.
Madam Regional Director, Mr. President, distinguished delegates, we would like to thank all those who organized events about NDCs this year, and we think that in New York and elsewhere in 2019 we will have other opportunities to discuss NDCs and international health regulations, and therefore we would like to certainly give our full support to this item on the agenda. The international health regulations give us a good opportunity to combat NDCs, and we hope that the WHO international plan for the fight against NDCs will be put into practice as efficiently as possible. In Switzerland, the international health agreement has, rather the Universal Health Convention has been fulfilled, and we believe that in protecting health systems and implementing health for all, we've been doing everything in our power to achieve the universal goals under very difficult circumstances in many cases. Together with Afghanistan, Switzerland will be organizing an event on the occasion of the WHO General Assembly this year, and we will also be organizing an event in New York on the basis of the same initiative. Our appeal to action, which has been further promoted since the General Assembly in 2018, has helped us galvanize our measures in order to achieve universal health coverage on the highest level possible and as soon as possible. Thank you very much for your attention.
Thank you, Switzerland. Germany, please.
Vielen Dank.
Thank you, Chairman. I would like to express my appreciation for the conferences in Tallinn and Sitges and their organization. One of our most important goals is universal health care, and this is because it gives people security and can also be an economic driver. We would like to thank our region and Estonia for putting Tallinn on the map by organizing this very important event, which is important for all of us. And I think that Germany is a very good example of the fact that it is worth investing in health. 135 years ago, in Germany, we introduced a general health insurance system. So that far back, we already ensured that no matter what their salary is or their income is, persons in our country have access to the best possible health coverage if they fall ill. What is decisive here is not only to have good universal health care, but also how that health care is provided. Our healthcare system is a part of the social market economy in our country. Solidarity is a very important pillar of our system. Solidarity between the younger and older citizens of our country, between those who earn more and those who earn less. All of this, of course, is linked to efficiency, which we strive to achieve. And we want solidarity to be something that we can pay for, and at the same time with which we can achieve good quality. At the same time, with 5.5 million people employed in the health sector, it is a very important economic factor in our country, and therefore general or universal health care is part of our prosperity, our economy, and also of the social fiber of our country. That doesn't mean we can simply rest on our laurels, however. Rather, the German healthcare system has to rise to new challenges time again, even if it is a good system. For example, there's demographic change we have to deal with. There is the rural economy and the fact that costs are rising in the hospital and medicament sector. Ladies and gentlemen, we must strive to ensure that healthcare remains something that we can pay for and that leaves no one behind. Thank you very much.
I don't see any requests from the member states. Then we are moving to the non-state actors' statements. And then I'd like to first invite the Northern Dimension Partnership in Public Health and Social Well-being.
Thank you. Dear Mr. President, Your Excellencies, Madam Regional Director, distinguished delegates, ladies and gentlemen. I'm honored to address you on behalf of the Northern Dimension Partnership in Public Health and Social Well-being, and I highly appreciate the opportunity to participate in this important event. Today, NCDs represent a leading burden to human health and well-being, and in this regard, our partnership has joined the global efforts to address challenges in this area. As an intergovernmental network that provides a platform for regional collaboration with various stakeholders, our partnership welcomes the commitment expressed in the outcome statement of the high-level meeting Health Systems Respond to NCDs and in the draft resolution of the WHO Regional Committee. I'm pleased to note that the action lines in those documents are, to a great extent, similar to the priorities and activities of our partnership. Prevention of NCDs, being one of the main goals of our partnership, is included in our founding document, drawn up in our long-term strategic plans and implemented by our dedicated expert groups. The partnership has joined efforts to address also the major risk factors of NCDs. As an example, the NDPH's declaration on harmful use of alcohol was adopted this year by the partnership high-level annual conference in Tallinn under the Estonian chairmanship of the NDPHS. This declaration, in particular, recognizes the critical role of international cooperation in complementing and supporting national efforts to generate an adequate response to the harmful use of alcohol. While the WHO has the leading role in coordinating the implementation of the global and regional strategies of NCDs, the established structures and commitment of our partnership provides an excellent platform for cooperation with the WHO in combating the NCDs in the region. Since the WHO is represented in the expert groups of the NDPHS and is co-chairing the NCDs expert group, we will have many opportunities to further reflect on our partnership's contribution to this important work and look forward to our continued fruitful collaboration. Ladies and gentlemen, we strongly believe that mobilization of all relevant actors and efforts will lead to a better sense of ownership and ensure the broadest possible commitment towards the fulfillment of common goals. With this, I thank you for your attention.
Thank you very much. The next statement comes request from the joint statement of different non-state actors. I will Medicus Mundi International, VEMUS, International Association for Hospices and Palliative Care, World Organization of Family Doctors, World Federation of Occupational Therapists, Council of Occupational Therapists for the European countries, International Federation of Medical Students Associations, Public Services International, European Public Service Union, Studio Room, European Public Health Association, World Federation for Medical Education. Please.
Thank you, Mr. Chair. Yes, it's 13 non-state actors that I'm speaking on behalf of, so that says something about the importance that we attach to this. It's a statement that relates to the report on the Sitges meeting, health systems response to NCDs, on the report on the Tallinn meeting, health systems for prosperity and solidarity, and it also bears direct relation to the draft resolution reaffirming commitment to strengthening health systems for universal health coverage, better outcomes, and reduced health inequalities. The undersigning 13 non-state actors would like to bring two pertinent issues to your attention. One is that the economic recovery of some countries in the European region will lead to a growing number of vacancies for health and social workers in those countries. As many of their domestic health and social workers have left the health sector definitively during the preceding times of austerity, it proves difficult for some countries to fulfill these vacancies. This situation may create a strong pull effect on health and social workers in other parts of the European region, as well as from low and middle income countries elsewhere in the world, which may result in increased health worker mobility and weakened health systems in the countries of origin. Therefore, it remains top priority to invest in a strong health workforce in all countries of the European region, including retention policies as a way to prevent excessive workforce migration on the basis of solidarity and mutual responsibility, and on the basis of solid data. We ask for your continued efforts to achieve this. Second, we would like to remind Member States of the currently ongoing third round of reporting on the WHO Code of Practice on the international recruitment of health workers. Both the national reports that are expected from Member States' governments and the independent stakeholders' reports from civil society form an important source of information for the WHO Secretariat and the World Health Assembly in May 2019. We therefore strongly urge Member States as well as civil society to provide WHO with relevant data and case studies on international recruitment of health workers, health worker mobility, and its consequences on health systems in the European region. Without these country-based data and analyses, all efforts to improve the implementation of the WHO Code and to strengthen the health workforce are aimless and ineffective. Thank you.
Thank you very much. The next statement is from the Standing Committee of European Doctors. Please, my request is we are very much limited in time, if possible, to limit by 2 minutes.
Thank you, Mr. President. I'll make it in 2 minutes. Honourable delegates, ladies and gentlemen, the Standing Committee of European Doctors, CPME, welcomes the opportunity to submit a statement on this report of the WHO high-level meeting. CPME especially welcomes the progress made in reducing the burden of NCDs as the leading cause of mortality in the EU. In all relevant policy initiatives, CPME aims to tackle behavioral risk factors such as tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. In line with the objectives of the Action Plan for the Prevention and Control of Non-Communicable Disease in the European region, CPME is advocating for the implementation of evidence-based and enforceable policies at EU level. In the context of the review of the EU legislation on excise duties applied to manufactured tobacco and the possible taxation of novel products, CPME is supportive of policy measures which follow the best buy recommendation on taxation as reaffirmed in the action plan. CPME will therefore continue to highlight the cost effectiveness of taxation as a tool to reduce tobacco consumption and to ensure coherence between health policy and tax policy objectives. Then, in the effort to reduce alcohol-related harm, CPME is calling for review of EU legislation to require a mandatory list of ingredients and nutrition declaration on alcohol product labels too. This policy innovation would aim to further align EU laws on food labeling with WHO recommendations and replace unenforceable self-regulatory systems governed by the alcohol industry. As is acknowledged in the action plan, combinations of actions are important to improve effectiveness. And lastly, CPME is calling on the European Commission to propose a legislative limit for industrially produced trans fats in foods. In line with the action plan's objective on reformulation, such a limit would not only reduce the direct harm caused by an excessive consumption of trans fats, but also combat health inequalities by especially benefiting vulnerable groups such as low-income consumers. CPME continues to advocate for the use of EU legislative tools to this end to optimize the implementation of the action plan. Thank you.
Thank you. The next statement comes from the World Heart Federation.
This is a joint statement on behalf of the World Heart Federation and the European Heart Network. The World Heart Federation and the European Heart Network commend ministers and government representatives for the commitment they demonstrated in the outcome statement of the high-level regional meeting. And we further commend the Euro region for its commitment to adopt the best buys and its significant progress in reducing the number of premature deaths from NCDs, such as cardiovascular disease, where we see the greatest reduction of any WHO region. We hope this outcome encourages governments to adopt a more ambitious goal, as this was already discussed at the WHO European meeting of national NCD directors and program managers in Moscow in June of last year. Despite this highly commendable progress, member states in the European region can still do more. Tobacco use is the single greatest preventable cause of NCDs, and the Euro region has some of the highest smoking rates in the world. Alarmingly, adolescent tobacco use is actually increasing. Despite this, fewer than half of the member states in the region have raised taxes in line with WHO best buys and FCTC recommendations. When it comes to diets, at a population level, dietary risk factors are a major contributor to CVD, responsible for 56% of all the years lost to disability or death from CVD in the European region. We therefore recommend member states to fully implement the FCTC's recommendations. Particularly, we urge governments to introduce or increase taxes on tobacco products to ensure that these products are less affordable. A population-based approach that aims to reduce the whole population's exposure to dietary risk factors offers great promise. Effective measures include food taxation or subsidies, regulatory controls on marketing of unhealthy foods, nutrient profiles, legal limits for trans fats, mandatory nutrition standards for schools, hospitals, and public places, aligning agriculture and food policies with public health objectives, and ensuring that trade and investment policies protect and promote public health. We call on governments to maintain their political commitment, and we urge heads of states, ministers of finance, foreign affairs, development, and health to attend the high-level meeting in New York next week to to commit to better health and improved economic development in their countries. Thank you for your attention.
Thank you very much. We have one joint statement which is by from the Medicus Mundi International and VEMOS, which is submitted in a written form. And with your permission, I would like to give floor to the Dr. Mikkelsen and Dr. Kluge to respond to the questions very shortly, if possible, because we are big.
Yes. First of all, thank you to all the very useful intervention, and I'm very happy to hear that the focus on best buys is still absolutely accepted and recognized. We must have to continue our fight against tobacco, and there is a request for really addressing inequity and also food obesity in the region, as we saw from the regional European health report and also other publications. Taxation is still the most efficient way of fighting many of these risk factors. I'm also happy to hear that the Nordic pinpointed other risk factors like air pollution. And there is a clear view from our end as well that we need to continue intersectoral, cross-border, and also focus on social determinants of health. We know that even with hard work, it will only be effective to achieve the targets if we also look beyond the health sector. Actually, 2/3 of the interventions on NCD effectively needs to go beyond health. For those who commented on universal health coverage, also from the area of NCD, we see that the focus now on primary health care and primary health care as the road to universal health coverage is extremely important, and we look forward to the Almaty meeting. And we also see that many of the things that are sort of embraced in the new global program of work 13 is speaking to the area of NCD. So we see the area of NCD both in universal health coverage, but also in emergency and in the area of well-being. The last interventions from non-state actors and the focus on FCTC is extremely important, and we are very happy to see also many heads of states coming to the UN high-level meeting next week. I would like to make a specific comment on alcohol. I think we will try to really accommodate what has been mentioned from the Nordic, and also thank you to Slovenia, who has organized for a side event on alcohol during the high-level meeting. We need to see how we can raise more interest. The area of alcohol is, beyond being a risk factor, also a very important area of work for how to work with non-state actors and to manage conflict of interest, and also definitely included in the work of life course, men's health, as we have launched and focused in this meeting. Thank you very much.
Thank you, Bente. So I will not go one by one, but 2 points here on the workforce to reassure you. Remember that we had the European Framework for Action on Sustainable Workforce adopted last year, and there are many initiatives. Just to point out, and one which came out of the Reykjavik meeting with the small countries, that there is now a work stream on sustainable workforce, particularly for the small countries. And 3 and 4 October, there will be the 2-yearly WHO Chief Nursing and Midwives Officer meeting in Athens, and I would like to thank Dr. Baskosas and the Ministry of Health for hosting this. And finally then, overall, I would like to express appreciation to everyone involved in this initiative, because this was what I would call, under the Health 2020, the leadership of our regional director, a positive, inclusive partnership. We cannot go to the countries and advise the countries to work together if we ourselves do not walk the talk. So the countries, you were in the lead, as Melita was telling, but we had a lot of experts, academicians, we had the partners involved, very important, the patients, the communities, and also explicitly the health professionals, the family doctors, the nurses, and all other health professionals. And we strongly believe that it's only through such an inclusive professional partnership that we'll be able to pull off this ambitious health system transformation Melita was pointing to, in order for our health systems to be 1, people-centered, 2, financially sustainable, and 3, resilient to future shocks. Thank you very much.
Thank you, Hans. I'd like to ask Ardi for final response.
I'd like to add just one more issue to what Bente and Hans have already highlighted. And this was raised by Estonia in the excellent presentation when she said that this item of Sitges should be more strategically placed on the agenda of the Executive Board in January when we discuss the progress reports and also the NCD-related issues. So I just want to reflect on this and to promise you that I will give this message to the Director General, and then when we review the Executive Board agenda, then we can consider its place. And actually next Monday we have a global policy group meeting anyhow in New York, and that will give us a good opportunity where we discuss also the outcome of the regional committees. Thank you.
Thank you, regional directors. Thanks the presenters and the participants of the discussion. Let us let's now continue with the agenda item 5J. On the outcome of high-level meeting on health system for solidarity and prosperity. The Secretariat has prepared a slideshow for you to relive some moments of this meeting, and please, slideshow. Thank you very much for a nice slideshow. I give the floor to the Dr. Elke Jakubowski, Senior Advisor for Policy and Strategy, to introduce this topic. As well, it's my request to you to be, because we are out of time. And
So, honorable delegates, good afternoon. So the meeting in June was hosted generously by the government of Estonia and was supported by the European Observatory. It brought together around 240 participants from 40 countries and many partners. As you've seen, we celebrated the 10th anniversary of the signing of the Tallinn Charter. And as we've seen before, much was achieved in the past decade in our region. So above all, a huge improvement of life expectancy by 2 years on average in our region. Now, as we've seen as well, this is largely due to progress in premature mortality on NCDs. That now makes Europe a champion worldwide. But as we've also just seen in Melita's report, we can do better with faster and more critical health gains. And because we can do better, the Tallinn meeting was designed to set out policy directions for the future. Policy directions on include, invest, and innovate that all reflect the values of the Tallinn Charter of solidarity, equity, and participation. Now, the first theme was on include, and that deals with access to services with coverage and financial protection. With include, we make sure that people are covered and are protected under their umbrella, as shown in this picture. Include lies at the heart of the global agenda towards universal health coverage. It's a priority under the GPW 13 and central to delivery on the SDG goal number 3. It is about ensuring that health systems reach and serve everyone without causing financial hardship. As the Tallinn Charter puts it so well and simply, no one should become poor due to ill health. Now, we had 2 plenary sessions in Tallinn on include, and Professor Charles Norman, who is sitting in the audience today, spoke about the 3 dimensions of universal health coverage. Who is covered, for what type of services, and at what cost to people. Ideally, he says, the whole population should have access to all the services that are of good value. For these, people would not have to pay out of their pocket for the risk of becoming poor. And then we had 2 panel discussions on include with ministers from 6 countries, Austria, Estonia, Georgia, Greece, Latvia, and Slovenia, all elaborating on their strategies on improving coverage, access, and financial protection. Now, we heard about quite a range of measures they've taken, and striving towards UHC is integral to all of them. So let me summarize the 3 key messages that came out of the discussions on include. First, that we reaffirm the Tallinn Charter that no one should become poor due to ill health. Second, that we need to enhance solidarity to ensure that no one is left behind, and also to scale up universal health coverage. And third, that we need to revisit and strengthen financial protection as a common concern across our region. Now, in the next session, following from this one, my colleagues Tamas Evitovits and Sarah Thompson will present new evidence on financial protection as summarized in this regional report here. So the second theme is on invest, and that stands for sustained health system investment for better health outcomes. Now, this is a prerequisite in making our health systems more inclusive, covering more people under the umbrellas, and innovative. Meeting participants confirmed that today there is much better awareness across the region that health systems are not only a driver of individual and population health, but also of wealth and economic growth, as has been set out with the Tallinn. But investment in public health remains as low as ever. So our focus was on understanding why, and with that question, we turned on how we make the business case on investing in health systems, in particular, in getting more serious about investing in public health. Now, you see here a sketch of a dialogue between a health and a finance minister that's steered by Geert van Manen from the Netherlands, who has been in both shoes over there. It enacts the health minister asking for more resources in view of increased health needs, and the finance minister disclosing concerns about the value for money. Now, the call for closer dialogue is not new, but our focus this time was deliberately on the finance sector angle, with a view to sharpen the point that health sector investments can work towards economic and fiscal objectives. In plenary and through parallel sessions, we heard from countries and we heard from key partners, including the European Commission, OECD, and the World Bank, on how they deliver on longer-term investments in health systems and what needs to be done to get more serious about investing in public health. Again, three key messages came out of the discussions on Invest. First, that we need to understand social and economic gains from system investments better. Second, that we also need to develop better ways to demonstrate that the health systems are worthy of continued investments and that they can contribute to the good stewardship of public resources. And third, more investment in public health and primary health care is required in order to increase the fiscal and the economic sustainability of health systems. We will follow up on this theme across the office and at forthcoming conferences in Gastein, Ufa, and Liverpool. Now, while it is clear that our health systems must be inclusive and sustainably financed, they will not deliver without keeping pace within the fundamental changes we regard within our health systems and outside. And with this, we turn to a third I theme, innovate. Again, in our Tallinn animation video picture, a big umbrella helps to bring all people under one roof. Now, that illustrates really a dream that innovations, would that be in systems, in services, or technologies, can bring about a more effective and more integrated way for us, helping us to deliver on health system values and objectives. Now, the session provided a platform for policymakers to share their experiences on harnessing innovations to meet people's needs, but they also shared their concerns on negative disruption of innovation, such as, for instance, on unequal access to services or increasing costs. And we discussed how they can better deal with it. We heard from policymakers that they struggle with scaling up innovations. And with that in mind, we had Professor Greenhawk and Nolte presenting the different stages of introducing innovations and failures in introducing and scaling up innovations. Now, context is relevant in all of those stages, but also so is governance that can come in and must come in at various stages. More practically, we heard from ministers from several countries who presented examples of how they steered and responded to innovations. For instance, Belgium has made access to new medicines for orphan diseases a priority for collaboration with neighboring countries. And to walk the talk on people-centeredness, Sweden has introduced new forms of health dialogues and primary health care with patients and their supporters using visual and digital tools. And Finland has created a national innovation platform to keep pace with emerging technologies. Again, three key messages emerged. First, scaling up is complex. Therefore, it's important to give organizations, services, and people sufficient support, time, and flexibility so that they can learn to function in new ways. Second, innovations of any type might threaten to widen health inequalities. Appropriate policy regulation is therefore vital to ensure that innovations are widely distributed and widely shared. And thirdly, people's perspectives on and priorities for innovation need to be considered if we are serious about people-centered health systems. I'm coming to an end, and it doesn't move forward. Okay, thanks. So now you need to move backwards one. I was too quick. Once again, we thank the team of the Ministry of Health of Labour of Estonia, our regional director, the Observatory, and our WHO country office in Tallinn wholeheartedly for their great support. But we also want to thank you as representatives of our member states for your support and also your engagement. We found it overwhelming. And you gave us a lot of inspiration, drive, and hope for the way forward. Thank you for that, and keep on board with us on following up on the outcomes of the anniversary meeting. The Observatory and WHO, our conference publications are available online, so visit us there. And thank you very much for your kind attention.
Thank you very much, Dr. Jakubowski. Now this floor is open for the member states. We have 3 requests for interventions. There is already 4 o'clock. Then my suggestion will be now to have a list of for the interventions, and we will continue with this discussion after coffee break. After the presentation of Dr. Jakubowski, we have a request from the 4 member states. Let's start with the Estonia, followed by Hungary.
Dear President, Regional Director, honorable delegates, it's a great pleasure to hear and see the principles of Tallinn Charter and 3 I's expressed from the first minutes of the Regional Committee and echoed throughout our discussions here. I would like to thank WHO for their help and support to organizing the conference, and all of you for participating and celebrating the 10th anniversary of Tallinn Charter together with us. We reform the Estonian health system now to be more inclusive, innovative, and also investing more in it. These principles will be included in our new National Health Plan 2030, which will strive to prolong life expectancy, increase healthy life years, and tackle inequalities in health. These objectives we will target through 3 programs of healthy choices, healthy environment, and people-centered health system. We agree that paradigm shifts towards people and their needs require that health literacy, which has been discussed in this conference as well, health literacy of people as well as health specialists become high priority, and this is one of our core activity areas to focus on in next decade also. We also would like to highlight the need to fight against inequalities in health. Besides local and regional inequalities of health services accessibility, there are 3 main areas we will focus on in the coming years. It's men's health, educational disparities, and protection of vulnerable groups. The latter we will target through slow but steady moving towards universal health coverage. Hereby I can assure that Estonia will be committed to the values of the Tallinn Charter, as well as 3 I's: invest, include, innovate. And we stand ready to share our experience with WHO and its member states. Thank you very much.
Thank you, Estonia. I would like to ask delegates of Hungary, followed by Russian Federation.
Dear Regional Director, Chair, Honorable Ministers, distinguished delegates, dear colleagues. Health systems in the European region are dynamically responding to the challenges of moving towards UHC and the Sustainable Development Goals. The Sitges and the Tallinn high-level meeting have highlighted many good policies and experiences, such as measures in order to improve access to health care services and reduce financial burden. We have been honored to be part of this meeting and share our pioneering experience in a number of areas. In April, we gathered in Spain to identify effective approaches to respond more ambitiously to the burden of non-communicable diseases. We were motivated by the inspiring examples for Europe combining intersectoral action with health system strengthening in an all-aligned manner to address social and behavioral determinants of health, including for the most vulnerable parts of the population. In June this year, we gathered in Estonia to celebrate the 10th anniversary of the signing of the Tallinn Charter. We reconfirmed our commitment to the Charter's values and recognized need to accelerate action for people-centered health system and to subscribe to a number of policy directions in the context of the high-level meeting. Three overarching themes include invest and innovate. The debate during the high-level meeting reminded us of the importance to call for more options for health policymakers to make the case for investing in health system, to accelerate the adoption, rollout, and scale-up of health system innovation, and most importantly, to move toward universal health coverage for Europe, free of impoverishing payments for health. Hungary, as a former co-chair of the Open Working Group on the CDGs, is fully committed to support the Universal Health Coverage Agenda, which plays a key role in achieving the Sustainable Development Goals targets to realize the universal framework of the 2030 Agenda. The UN General Assembly's first ever high-level meeting in the Universal Health Coverage will be held in New York in September 2019. Hungary is extremely proud to serve together with Thailand as co-chair of this UN high-level meeting entitled Universal Health Coverage Moving Together to Build a Healthier World. In our capacity as co-chair, we will ensure that the Sitges and Tallinn outcome statements to innovative work and on the health system respond to NCDs and financial protection developed by the regional office, as well as the 2019 Estonia Declaration on Primary Health Care will inform the preparation of the UHC high-level meeting. We very much look forward to delivering a successful UN high-level meeting with the support, contribution and cooperation of the WHO Regional Office for Europe and all the member states of the European region. Thank you for your attention.
Thank you, Hungary. Yes, Russian Federation, please, followed by Republic of Moldova.
Thank you very much, President. The Russian Federation appreciates the efforts of the European Office to strengthen health systems and intersectoral cooperation in the countries of the region in order to achieve the SDGs and, in particular, to achieve UHC and to strengthen health in general. The high-level meeting in Sitges and Tallinn have enabled us to catalyse the efforts of countries and to raise their expectations and to strengthen their efforts to take further steps along these lines. It's difficult to over-assess the innovative contribution of these promises when it comes to pulling together our work and collective view, what we call innovation, what we call implementation, what we call standardization. It is absolutely vital to prevent infectious diseases by ensuring that people have access to health care. It's also vital to invest in health care. It's vital to strengthen the primary chain in the healthcare sector. We understand the importance of countries using all of this work, and therefore we suggest that we include them in the initiatives of the regional office to create an interagency list of all of the initiatives that have been realized in our region with the various platforms, with the various instruments that help us to work at a country level. We call upon you to make this list publicly available, and we urge you to spread it so that member states, when implementing their priority measures, can choose for themselves the most appropriate ones. We pay particular attention to the fact that these instruments must be guided by and mechanisms must be translated into the country languages so that they can be introduced broadly. Therefore, Russia suggests translating the material of the WHO into the Russian language, and we look forward to the swift publication of the list. Thank you very much.
Russian Federation, Republic Moldova, please.
Mr. Chair, thank you very much. Madam Regional Director, Honorable Ministers, ladies and gentlemen, dear colleagues, universal health coverage is the heart of European Strategy Health 2020 and 13 WHO Global Programme of Work, while the principle of universal health coverage and equity is also embedded in Moldovan's National Health Policy 2008-2021 and National Health Sector Development Strategy. Moreover, the 2030 Agenda for Sustainable Development is explicitly setting 4 specific targets for achieving universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicine and vaccines for all. These targets inspire and drive policy development in our country. The Ministry of Health, Labour and Social Protection has been continuously strengthening and improving 4 strategic areas with the WHO support, namely hospital sector reforms, primary health strengthening, public health reforms and health financing. Most importantly, the integration of primary health care and public health services has been initiated. The Ministry of Health, Labour, Social Protection is also strengthening provision on the rational use and selection of medicine, contributing towards achieving the universal health coverage in Moldova. Also, in the same lines, National Human Resource for Health Development Strategy was developed with the WHO support, addressing, among others, the management of human resources, recruitment and retention of personnel, working condition, and performance incentives. Need for improving health information has been recognized. Moldova also engaged in very ambitious public health reforms while developing strategic purchasing capacities to ensure cost saving and better value of money. Specific activities will be carried out with the WHO support to develop a framework to address out-of-pocket payments and policy options to improve those. We express gratitude to the regional director and her teams and regional and country office for their excellent work and support. The Republic of Moldova supports adoption of resolution reaffirming commitment to health system strengthening for universal coverage, better outcomes and reduce health inequalities, and commits to the implementation of all 7 strategic actions on plan on health system strengthening. Thank you.
Thank you. As there are no member states asking for the floor, I would like to give the floor to observers. We have requests from 2 non-state actors, Standing Committee of European Doctors and Euro Health Net. Please, Standing Committee of European Doctors, you have the floor.
Thank you, Mr. President. Honorable delegates, ladies and gentlemen, the Standing Committee of European Doctors, CPME, would like to underline the role of primary care in providing universal health coverage. Primary care and its preventive, curative, and rehabilitative dimensions is the key to universal health coverage. And there are 3 points we'd like to stress. The first one is that high-quality healthcare must be accessible to every person who needs it without financial barriers. Second point, healthcare is an investment, and we demand political action in every country to provide the necessary resources. quality primary care is the best investment in people, in health, and in the economy. And third point, primary care is a team effort. It requires different levels of competency with clear responsibilities. CPME reaffirms that such an integrated network must be under the leadership of a medical doctor. National policies should definitely support such structures. CPME is committed to increasing its cooperation with WHO Europe in achieving and maintaining a strong, primary care-oriented, people-centered health system. Thank you.
Thank you. The Euro Health Net, you have a floor.
Thank you, Honourable Chair, distinguished guests. EuroHealthNet, the European partnership of national public health agencies and regional authorities, congratulates WHO on the progress made at the Sitges and Tallinn high-level meetings. We are pleased to contribute with some suggestions for continued development. Non-communicable diseases are increasing and are strongly related to the persistent health inequalities in Europe. Tackling NCDs requires urgent and joint action where health systems have a pivotal role. What we still miss in the reports are the preventative and health-promoting dimensions. Most of the factors linked with NCDs are largely preventable, as we all know. They require a stronger health promotion and disease prevention response. Health systems should take systematic and strategic action on those risk factors. It must engage in tackling broader societal determinants using its knowledge and its experience. Most of the health system concept is, however, still understood as health care. Even if the Sitges and Tallinn statements make due reference to cross-sectoral action as part of the Sustainable Development Agenda and refer to the importance of health equity, they fail to provide proposals for bold and effective actions and solutions. So we suggest to developing a much more explicit and meaningful approach to integrating health promotion and social determinants approaches throughout the health system with an increased role in primary care services. Social innovation is as key as technological innovation. We need truly health promoting systems and not a single health promotion compartment within a public health silo of a disease-centered system. The EuroHealthNet partnership is keen to work with the WHO and to discuss how this radical paradigm shift can be shaped inside and outside the health system. Thank you for your attention.
Thank you. Dr. Kolge, would you please answer the questions and remarks?
Thank you very much, Professor Amuran, and everyone for the interventions and additional thoughts and ideas. I think Tallinn was really a very memorable moment, and once again, thank you very much to the Ministry of Social Affairs, very timely to reflect how to reorient our health systems within the changed climate over the last 10 years, both in Europe and globally, in order to not to give in to the principle of breaking down of solidarity. So this was the why we had to come together, the solidarity. The what, the 3 I's, we hear very good feedback. We know that our populations are only to have will have equitable access to healthcare and public health services if our health systems first are inclusive, meaning leaving no one behind. And we're going to discuss this more after this session on the financial protection. Second one, if they benefit from sustained strategic investment, this was the second I. And the third I, if they are capable to innovate, to put really the people at the center, both their health and their social needs. And what are the next steps now is to assist the member states with the how. How do you pull it off? Basically by 3 streams. The first one, as both Dr. Tedros and Dr. Jakob were mentioning, to redouble our efforts on universal health coverage. Second, by the foresight, by thinking ahead, what are the main challenges and trends coming onto the health systems, so that our health systems no longer have to passively react, but can proactively take action on the future trends. And then the third one, on the actual transformation, to put the people in the center by engaging the people, and then, as you mentioned, by the sustainable workforce. In fact, the ultimate vision we came out of Tallinn was to have a society with a culture of health. And I think that relates with the last intervention as well, that there is an overarching societal culture where every individual has the opportunity to make choices for a healthy lifestyle. And in fact, it was the Tallinn Charter in 2008 which already stated that we in the health systems are central to promoting health and well-being to scale up to universal health coverage. Thank you very much, everyone, for your great input. Thank you.
Thank you, Hans. Before concluding this rich discussion and before moving to the adoption of the resolution, I would like to invite for two short statements on forthcoming high-level events. First, I would like to give the floor to Dr. Aniko Nagy, State Secretary of Health from Hungary. No? Huh?
She had done it.
Then the second one was from Kazakhstan. I don't see the...
They are not in the...
No? It's about Almaty,
So we move on.
Good. Thank you very much. I would like to consider the adoption of the proposed draft resolution contained in Euro/RC68 conference document /8 revised 1, reaffirming commitment to health system strengthening for universal health coverage, better outcomes and reduced health inequalities, and its financial implications contained in Euro/RC68/19 edit 1. And there have been a number of amendments, and I shall now ask the rapporteur to read out the resolution as amended. Ute, please.
Thank you. Referring to the operative paragraph 3, section D, there are two suggested changes proposed by Austria on behalf of the European Union and its member states. First, after the word that, the word excessive to be inserted before the word out of pocket. And second, after the word medicines, a strike through of the word are and an insertion of the words can be before the word a significant. So the sentence reads, recognizing that excessive out-of-pocket payments for outpatient services and medicines can be a significant source of financial hardship in many countries in the region.
Thank you, Outi. Having heard the amendments to the draft resolution, is the committee willing to adopt the resolution as amended? I see no objections. The resolution is therefore adopted. Thank you. Thank you very much for this very interesting discussion.